You're ready to be live.
Okay, and we are live. Hello, web shadowers. Thank you all for joining our session today. Today we have the pleasure of hosting Dr. Ellen Wood, who will be teaching us about endocrinology. And as per usual, the Google form will be posted in the chat box and in the description of this video at the end of the session for you to fill out within 30 minutes to get credit for this session. With that being said, Dr. Wood, you can start whenever you're ready.
Okay, all right. Well, first of all, I'd like to thank you, Sophia, for inviting me to give this presentation. I'm really very into helping out medical students and kind of trying to mentor them. My own daughter has been going through it for the last 4 years now. She's also pre-med, so I'm really happy to be here, and happy hopefully a lot of people can just get an idea about what I do. So basically, I am a reproductive endocrinologist. So I'm not a medical endocrine, so I don't do thyroid, I don't do diabetes, I only basically do pregnancy. And this is one of the subspecialties of OBGYN. And so I'm going to tell you just a little bit about me, okay? I've basically been an infertility physician. I finished my fellowship in 1999. I'm an avid exerciser. I've run 8 marathons, and I'm a mom of 2. My one daughter is 20. She's at Boston University. Right now, she's in her junior year, and she has been accepted into Boston University's dental school. My other daughter is 21, and she is now in a Master's of Graduate Science program at Philadelphia Osteopathic and has her applications in for med school right now. So she also graduated from Boston University. I am an undergrad. I graduated from University of Pennsylvania in 1988. Interestingly, my degree is in international relations, and I did a minor in Spanish. So every pre-med class that I took for medical school were electives, because I was very interested in Plan B in case I did not get into medical school. I needed an alternative, and I was thinking maybe law school. So, however, I did get accepted. So I went to Philadelphia College of Osteopathic Medicine. I graduated in '92. After that, at the time, we did not go right into residencies. So in the state of Pennsylvania and most osteopaths, we had to complete a rotating internship. So rotating internship, I did that for a year, which you go through all the specialties, and then we applied to residencies. So it was a little bit different than they are coming out of medical school today, which you apply to a match and you get into a residency. The first part of your residency starts off with a little bit of the rotating internship, different specialties, and then you get into your exact field. I did that at Philadelphia College of Osteopathic as well. And then I went into residency in OBGYN. In residency, interestingly, OB is a really fun field. It's super duper fun. You get to deliver babies, you get to learn how to do surgery, you get to see patients in the clinic. So it's a wonderful specialty. The problem is the hours are not that good. Okay, so because of that, at the time, my husband is also an OBGYN, and we decided that we were going to have to do a subspecialty if we wanted a life and we wanted to have children. So in order to do that, we had to say one of us was going to be a subspecialist. So at the time, there was 3 subspecialties you can do from OBGYN. You can do gynecological oncology, which is cancer surgery, which is wonderful, fun surgery. The problem is it's a little depressing because everybody has cancer, and some people, even though you're the best surgeon in the world, they don't make it. So it's a little sad. So we decided that wasn't for us, or one of us. You could do high risk obstetrics, which is called maternal fetal medicine. And in maternal fetal medicine in Pennsylvania, where I was practicing at the time, they also deliver babies. So this kind of was something that wasn't going to work for us because we both have these terrible hours delivering babies in the middle of the night. So maternal fetal medicine wasn't even on our radar. Now, I have subsequently learned that maternal fetal medicine in some places, they do not deliver babies, like where I am in South Florida. So all the maternal fetal medicine specialists down here, at least 90% of them, all they do is consultations, ultrasounds, office, things like that. So they have good lives. So it could have been an option for somebody who was looking to do obstetrics, but not actually have those hours. And then the third specialty was reproductive endocrinology and infertility. And that is what, you know, I'm in right now. So what happened was I was going to be the general OBGYN. My husband was going to do the infertility fellowship. I sent him off on his first week in fellowship, and he comes back and he's like, I hate this. He goes, this is not fun. I don't want to do this. I'm like, uh-oh, that's not good. So subsequently, I did the reproductive endocrine rotation as a third year in OBGYN residency. And I was like, this is awesome. This is like the funnest thing ever. And so I go, all right, I'll be the specialist. So I applied and I did my fellowship in REI at Pennsylvania Hospital. And then what happened was Pennsylvania Hospital got bought out by University of Pennsylvania. And the group that was training me basically got kicked out of Pennsylvania Hospital. And we had to move over to Thomas Jefferson. So I finished my fellowship at Thomas Jefferson. I practiced for a year in academic medicine. That wasn't for me. It wasn't, we weren't kind of busy enough, let's say. And then I interviewed all over the country, and I ended up joining a private practice here in South Florida, which is called IVFMD. We have a wonderful website, www.ivfmd.com. It tells you everything that we do here. And I've been in South Florida since October of 2000. So I'm over 20 years with this practice. And it's just the funnest job ever. So if anybody is thinking OB, you know, this is really fun, this job. I can't say enough about how much I love it. So that's me. But so I'd like to talk to you guys today about the infertility evaluation. So the infertility evaluation, what I'd like to go through is just kind of a classification, causes of why patients might be infertile, kind of teach you guys how to do a history and list components for you know, a focused physical exam to evaluate a couple for infertility. Talk to you a little bit about some diagnostic tests to determine what might be the problem. Describe an appropriate treatment and the varied causes that we see commonly for infertility, and then talk to you about the prognosis of the condition for the patient. So when my daughter reviewed this lecture, she said to me, she said, Mom, she goes, I think you need to start off with a little bit of this menstrual physiology. And because of that, I put in this first slide. Oops, I'll stop and answer this question if you guys don't mind, hopefully. Did your non-traditional major make it hard for you to do research and academic med? This was really 20 years ago, or actually longer than that. And I actually, at the University of Pennsylvania, where I was in undergrad, we had an insane amount of research opportunities. I mean, every single day, because we had Penn Med right there, there was like research assistant needed. So I actually did research as an undergrad with, we cut the little heads off of rats, we put the brains out, and we looked at the lipid content in them after the rats had been exposed to certain different chemicals and stuff. So when I was back in school, there was just literally research opportunities just like hemorrhaging. So it did not have an issue for me whatsoever. But I have talked to people nowadays that the non-traditional majors do have more of a difficult kind of getting like an in and getting them. So hopefully I answered that question. But for me, it wasn't an issue. I had my pick. At the one time, I said, all right, what kind of research do I want to do? I could do chromosomes, I could do genetics, I could do this. I had like 6 different jobs that I could have done easily. But anyway, that was a while ago. Things have changed. All right, so I want to start off talking about the basic menstrual cycle. Okay, so even though a lot of us probably listening are women, okay, and we know our period should come monthly, many of us do not actually understand the physiology about why a period comes. Okay, they just say it should come every day, on this day each month, and if it doesn't come, oh my God, I might be pregnant, or there might be something wrong. So the way menstrual physiology works, in the beginning of your cycle, we have these little teeny things that are called follicles. Okay, inside the follicle is something called a granulosa cell. A granulosa cell is something that secretes the hormone estrogen. Okay, as the follicle gets stimulated, okay, by the brain, something called FSH, or follicle stimulating hormone, it makes these granulosa cells proliferate. So they grow and they grow and they grow. As they grow, the granulosa cells grow and the estrogen level rises. This is thickening the lining of the uterus. Okay, so this is basically what we call the endometrium. The endometrium, okay, the growth of it acts like a brick. And so you put brick over brick over brick. So it's like a wall growing. And so more estrogen, the more bricks that grow on top of themselves. Now, once the estrogen level reaches a level around 200, 250 picograms of estradiol, the brain's like, hey, there's something, there must be an egg around. And it sends out a pulse of something called luteinizing hormone. Luteinizing hormone, okay, only stays in the body for a very short amount of time, 18 to 24 hours, but it sends that signal to the ovary to release the egg. So now, once the egg is released, we see a drop in estrogen. It slowly starts to rise again, but now we see production of something called progesterone. The progesterone hormone is kind of like the cement. It's like the mortar that holds these bricks together. Okay, so it holds the whole lining together. And what it's doing is it's making a bed for the potential baby. So the whole menstrual cycle, the only reason to have a menstrual cycle is for reproduction. Okay, that's it. There is no other reason that women should bleed every month. Okay, so I'm a big fan of continuous pills. Just stop your menstrual cycle, never get a period. I think it's a wonderful way to go because the menstrual cycle is only meant for reproduction. That's why it exists. So what happens is 1 week after you ovulate, this is when we have implantation. Usually it occurs right around here, about 5 to 7 days after you ovulate. And the progesterone is what solidifies the lining of the uterus and allows the baby to implant. Once the baby implants in the lining of the uterus, it starts to secrete a hormone called HCG. HCG feeds back on this corpus luteum here, and the progesterone stays up because it's supporting a pregnancy. If no pregnancy occurs, progesterone drops, therefore the bricks fall out, okay, and the crumbly wall falls out, you get a period, and we start the whole cycle again. So that's just, a little explanation of why women have periods. And so there's lots of other conditions that, it's a whole lecture in itself, why the periods are off for another day. But I just wanted to throw out a little bit of menstrual physiology just to educate you guys. I mean, you probably see the stuff in your physiology class, but sometimes people still are a little bit confused. Okay, so moving on. So the first case I'd like to present, okay, is these are common things that I see every day. So I'm a gynecologist, so most of the time the patient just presents by herself, okay? We encourage the patient to bring her husband with us. So it's a 29-year-old woman. Her chief complaint is that she has not gotten pregnant. She's infertile. And she stopped her birth control pills last year. And she's not pregnant. So does she meet the diagnosis for infertility? She stopped her birth control pills a year ago, not pregnant. What do you guys think? Okay. And then also, if anybody wants to, type it in, answer the question, what do you guys think is the most appropriate next step? Like, what should I do? Like, what should I do when she comes in? Anybody have ideas? Okay. So a question, can you do a subspecialty in OBGYN and find time to have a lab? Would you say aren't really all OBGYNs have clinical research labs? Yeah, most OBGYNs, it's a residency specialty. And for OB, in academics, sure. Like there's lots of universities that employ, like what I started off with. So I started off in an academic practice at Hahnemann University. And so basically I worked for the university. We had, research, we had clinics, we worked with the residents. So the only difference with having to do research and stuff is if you work for academics, tons of research opportunities in OBGYN. I'm in private practice. We have research going on in our private practice, but it's privately funded by ourselves. We're not paid to do it. We're paid to see patients. So that's why we don't do a ton of research in private practice, but there's plenty of OB research opportunities in university settings. All right, someone's answering my questions. Okay, cool. So possibly needs testing, check hormone levels, what kind of birth control is she using? Good question, that's excellent. Yeah, so the kind of birth control would determine like when her periods came back. So certain birth control, your periods are going to come back quicker than others. So the depot shot may take a while for the periods to come back. When you're using just birth control pills, they should come back within 1 cycle. If you're using an implant, they should come back within 2 cycles. If you're using an IUD with hormone, it should come back within 2 cycles. Without hormone, without a hormone IUD should have just been come back right away. But there is a hormonal IUD that will delay your period by a month or 2. All right, excellent. Okay. So let's just start with the definition of infertility. Okay, so what's the definition of infertility? Couples that have to have regular protected intercourse, we're going to have 50 to 60% are going to get pregnant in 3 months. 70% after 6 months, 85% conceive after a year, 90% after 2 years. Okay, so infertility in a patient who's under the age of 35 has to be the failure to conceive after 1 year. Okay, because 85% of people you're trying for a year. Okay, and we're assuming that we're having regular intercourse, things like that. It will affect 10 to 15% of couples. So hence that's the population that I see is this 15% of the population that hasn't gotten pregnant within those first couple of tries. So there's 2 types of infertility, and this is the definition here. So primary infertility is when you've had no pregnancies, and secondary is infertility when you've had a pregnancy and now you're having difficulty conceiving. Now, the definition is a little bit different, okay, if you're older. So if you are a woman and you're over 35 and you haven't conceived in 6 months of unprotected intercourse, that's considered infertility. So under 35, usually your doctor will say, wait a year, it should happen. There's an 85% chance it'll happen. If you're over 35 and you haven't conceived in 6 months, we'll start a workup. Let's see. Okay, so evaluation and treatment prior to a year is also appropriate. So if the patient comes to you, hey, I've been trying for a year, and you say to her, are you having periods? And like, well, I've only had 2 periods last year. Okay, you probably should start the workup a little earlier. If you think she has any risk factors for a uterus to have a problem, her tubes to have a problem, you should probably start the workup. You know, shouldn't say come back, after a year. Or if the male partner would be suspected of having anything, we should probably work you up sooner than that. So, but if it's just, healthy 29-year-old girl, comes in, her periods are regular, they're not taking any medicine, and they've just been having, unprotected intercourse, at that point, a year would be when they deserve a workup. So what are causes of infertility? So one of the main causes of infertility is going to be ovulatory problems, okay? So either the ovary has stopped working, which is early ovarian failure, which is ridiculously common. You have no idea how many patients I see in their 20s and their early 30s that their ovaries are just up and stopped working. So that's basically early menopause. There is something called hypogonadotropic hypogonadism. And what that basically means is that your hypothalamus is no longer talking to your pituitary gland, okay, to produce that FSH hormone to get your ovaries to make eggs. It happens in patients who exercise too much. It happens to patients who are underweight. It's kind of rare. We don't see it very much. I mean, I probably see hypo maybe once or twice a year, but it's not a common thing. Now, polycystic ovaries, that's something that we see on a daily basis. So that is a very, very, very common disorder where women have too many eggs. Okay, so instead of having too few eggs when you're menopause, you've got too many eggs. And because there's too many eggs in the ovary, what happens is those FSH signals, okay, they're trying to talk to the ovary, but the ovary, instead of having just, maybe 5 or 10 little follicles in it, it has 25 little follicles in it. And because of that, the ovary does not respond to that FSH signal that the brain sends out. It's kind of like trying to talk to a crowd without a microphone. Nobody pays attention. So that's what happens with polycystic ovaries. Very, very, very common disorder, very easily overcome with some medication treatments. And then elevated prolactin levels are something that also will mess up your ovulation. If your prolactin level is too high, it also will suppress the FSH signals that your brain sends to the ovary to get it to ovulate. So ovulatory dysfunction, big cause of infertility. Endometrial uterine problems, if there's any lesions inside the uterus, any growths inside the uterus, it can cause implantation problems. Tubal obstruction, okay, having blocked fallopian tubes clearly is going to be a problem. Having a cervix that is stenotic, okay, is also going to be a problem. If someone has had surgery on their cervix, they've had cryosurgery, they've had a LEEP, they've had a freezing, anything like that. And then male factor, okay, and there's different categories of male factor. They're called azospermia, that's no sperm. Oligospermia, low sperm count. Asthenospermia, when the sperm aren't moving too fast. And then there's teratospermia, where the sperm just look funny. And then if we worked you up for those things, they basically unexplained infertility. So does birth control, this is a good question, I'll address it now. So does birth control for a long time affect the cycle, or menstrual cycle, or fertility? In most women, no, okay? And so interestingly, and I think we get to this a little bit later in the lecture, but interestingly, your ovary has as many eggs as it's ever going to have, and they're just going to die off at a genetically predetermined pace. So sometimes people will think that if you don't ovulate, which is when you're taking birth control, you can kind of save up those eggs. It doesn't work that way. The eggs, it's use them or lose them. So you get 100 eggs that step up to the plate 1 month, okay? And then if you don't ovulate, the 100 die. The next month, 100 step up to the plate, another one dies. So birth control, you can take it for 5 years, you can take it for 10 years, you can take it for 15 years. It is not going to alter how many eggs you have at the end when you stop the birth control. So it's just for prevention of pregnancy. It should not alter your fertility in any way, shape, or form. What would lead to suspicion a person with testes is not the issue. Would it make sense to check this before going into tests? Oh, tests on a person with ovaries. Tests is not. I'm not sure. I'm not sure what it is. Testes or tests is the question. So we'll move on to the percentage of causes, and then we're going to get to that because it's in the case. So frequency of infertility diagnosis. So again, we have all different frequencies. In general, we have 18% multiple factors, 14% are tubes. We've got ovulate function, but diminished ovarian reserve, like premature menopause, endometriosis, uterus, male factor, sometimes these causes interlap. Again, multiple factors is about 13%, 11%, 11 to 15% are really kind of unexplained. But these are the major causes, but they're all over the place. And again, sometimes we'll have patients who have 2 and 3 of the diagnoses together. Okay, so the basic fertility evaluation, we're going to start with a medical history of the male and female partner. We're going to start with a focused physical exam. We're going to obviously do a semen analysis, detection of ovulation, egg reserve, check the tubes, do a uterine evaluation, and then counseling. So this patient, medical history, we're going to do a duration of infertility. So obviously when we do a history, we want to say to the woman, how long has it been trying? So this patient, she's been 12 months. We're going to do a sexual history. We're going to check for prior evaluation and treatment. We're going to see how many times she's been pregnant before. We're going to do her GYN history, looking at her menstrual patterns, whether she has pain with her periods, okay, because that could lead to suspicion for diseases like endometriosis or even fibroids. History of sexually transmitted diseases, okay, which is going to make us think of possibly tubal problems. We're going to see if she had pelvic surgery. We're going to look at her cervix, uterus, adnex, appendix, see if she's had any of those things operated on. We're going to look at a basic medical and surgical history. We're going to see what meds she's taking, whether she had drinks or smokes with her habits, or marijuana is a big one. We've added that into the repertoire since it's such a popular thing these days and has a dramatic impact negatively on fertility. We're also going to look at her family history. How old was she when her mom went into menopause? And we're going to see if there's any genetic diseases that potentially run in the family. The male partner, we want to see if he has a history. So has he been married before? Has he tried to get other people pregnant? Has he ever seen a urologist? Does he have any kids? Has he had trauma to his testicles? Okay. Was he born with undescended testicles as a baby? Has he ever been diagnosed with a varicocele, which is a bunch of veins around the testicles? See if he has any of those things, because that's a key thing as far as being suspicious of male factor infertility. We're going to see if he has any medical problems. Is he diabetic? Has he had any surgeries, like a vasectomy or a vasectomy reversal? These are really important. Is he taking any medications? Sometimes medications that men are taking can affect how their sperm are produced, and it can also affect the ability for that sperm to actually make it into the egg. We're going to see also if he smokes marijuana, which we've seen affect sperm DNA, which is just crazy. But we see, yeah, we're getting to that one. The appendix question, we're getting to that one in a second. That's coming. The habits of the gentleman: smokes, drinks, and again, any marijuana. Hot tub use in guys is also something that is really, really important to ask about when you're looking at fertility evaluation, because testicles are affected by heat. Okay, you can go into a hot tub greater than 101, and basically that can be birth control for a guy for the next 3 months, since it takes 72 to 90 days to make a sperm. Sperm are very, very, very sensitive to heat temperatures over 101 for more than 15 minutes. So also what happens is if you get a fever, so if a guy has, recently had the flu or had COVID or something like that, and if he's had a fever greater than 101, it wipes out the sperm production in the testicle, and they will start to regenerate, but it takes about 3 months to even get sperm back. And we also look at infertility history. Did his parents need fertility treatment? Does he have any brothers and sisters? Also, is there any genetic disease, in the family? Is very, very important for the male part of the history. On the physical exam, okay, for the female, we want to look at her weight. Okay, is she too thin? This could cause her brain and her ovary not to talk, because the body, interestingly, when you're underweight, it's actually pretty cool that the body does this. The body can sense if you have enough body fat, okay? If your body fat is too low, it will shut off the signals from your brain to your ovary, and it won't let you ovulate. The reason being is that your body is trying to prepare itself for pregnancy, and it knows that more than half women who get pregnant, okay, have nausea, vomiting in the first trimester of pregnancy. So your body has to prepare for that and has to make sure you have enough fat stores that if your calorie intake, because of the nausea and vomiting of pregnancy, drops down very, very low, the body is going to be able to suck something from that reserve, from that fat, which is why your body doesn't let you be pregnant if you're too thin. I mean, that's just the bottom line. It's a very, very interesting physiologic mechanism, but, when, people have been having babies for thousands of years, it's the same thing, that if you're undernourished, your body won't let you reproduce, because it's less likely to help the pregnancy survive, because babies are like parasites. I mean, they suck off of the mom, because they come in and they're sick of oh my gosh, am I getting enough nutrition to the baby? I can't eat, I'm throwing everything up. The babies make it. If you have those reserves, the babies make it. And then once you can eat again, so we never really worry about weight gain in the first trimester, because your body allowed you to be pregnant. You have enough reserve. Now, what happens is if you're overweight, okay, it also will shut down your ovulation, especially if your BMI is over 30. Because what happens with fat cells, so if you're too heavy and you've got too much fat, that fat secretes extra estrogen. So estrogen works as a feedback mechanism for that FSH hormone. So if your body thinks that it has enough estrogen around, it's not going to send out any of those FSH signals to tell your ovary to ovulate. So ovulation will shut down if you're too thin, because it doesn't want you to be pregnant, and it will shut down if you're too heavy, because if you're too heavy, your body's like, we're good, we don't need to make estrogen. Why do we need to make any follicles? There's two opposite sides of the spectrum. And so this is why body weight is quite important when we're evaluating a fertility patient. It's also really important that you check their thyroid, okay? Make sure they don't have a goiter, make sure they don't have any nodules in their thyroid. We also want to assess their breasts, check for nipple discharge. Nipple discharge could be indicating that your prolactin levels are too high. And if your prolactin levels are too high, it's also altering the way your pituitary gland functions and tell your ovaries to work. We look at the patient's skin, if they have acne, if they have extra hair, that's hirsutism. Also, if they have something called acanthosis nigrans. Acanthosis nigrans is like a brown plaque that you'll see it in the back of the neck. You'll see it on the inner thighs, and it's indicative of higher insulin levels, which are indicative, like the hirsutism, the extra hairiness, and the acne, which is indicative of elevations in testosterone, what we call hyperandrogenism. Hyperandrogenism is something that is seen super commonly and is one of the criteria for a patient with polycystic ovaries. And that is on the list of things in patients who are having an ovulatory problem. So these are all things that are just kind of mulling around in your head as you're kind of first getting their history, then kind of looking at them and examining them. So what's going on with this patient? Like, why has she for a year not been able, to conceive? So in the case, okay, she's a 29-year-old woman. She comes in, again, primary infertility because she has not been pregnant for a year of trying. She stopped her birth control. She's having intercourse 2 to 3 times a week, okay, and that's appropriate. So sperm will live, okay, they can live for up to 5 days. But normally it's 72 hours, you say, a sperm. So if if you have sex on Wednesday, those sperms should be, around on Friday, in order to fertilize the egg. So again, 2 to 3 times a week is going to be a time that's going to kind of cover you, that there's kind of active sperm around all the time. She's G0, meaning gravida 0. So she's never had a pregnancy. Her menstrual cycles came back easily after she stopped the pill. So they're every 28 to 30 days. She's had normal PAPs. She has no history of STDs. Her medical history, she's got no history of, diabetes, no history of high blood pressure, no history of, seizures or blood transfusion, anything like that, no thyroid disease. However, in her surgical history, she has had a ruptured appendix. So this is definitely, as soon as I hear ruptured appendix, it's like, bingo, the light bulb goes off. So that's definitely going to be on my differential diagnosis as far as, what I'm considering might be the problem. She is taking a prenatal vitamin. She's been married. She does not drink. She does not smoke. And the husband, we talked to him. He comes in with his wife. He has no children. He's never had any issues before. He has no injury or infection. Normal sexual function. Again, sometimes you'll see couples, and it's really interesting. And you'll ask them, are you having sex? And they're like, no. And I'm like, okay, why? And we're wondering why you're not pregnant. And they have ejaculatory dysfunction. So they have erectile dysfunction. They can't have an erection. And basically they'll come to us, and what we'll do is we'll get sperm, and we'll get sperm, we send them to urologists. We'll get them to give us sperm, and then we can put it into the uterus and do insemination and inseminate her. But so normal sexual function, making sure that they're actually having vaginal intercourse, as well as able to have intercourse, is very, very, very important. And sometimes people aren't very forthcoming with that. So that's sometimes a history you have to kind of pull out of them. I had an Indian couple probably 4 or 5 years ago, and how long have you been trying to get pregnant? 4 years. Okay. And we go through their history. I go in to examine her. Okay. And you can't examine her. Her vaginal opening, I couldn't even touch her, and couldn't even get a pinky in. It was, the poor thing had a hymen that was imperfect. But they came in telling me they're trying to have a baby for 4 years. So anyway, just, you have to really, really look at everything when you're looking at a couple, and we always look at them together. This husband, he's had no surgeries, no meds, he's married, has a drink occasionally, has no tobacco. So when we did the exam on the female, she's 5'3", she's a BMI of 22, good blood pressure, physical exam, it looks normal. So what would you recommend next? Okay, I think someone has already kind of said it in the beginning. And what we would recommend is obviously an examination of the sperm, because she's, besides the appendix, which is a little suspicious, everything in her menstrual history sounds like she is ovulatory. He looks good too, but the semen analysis is one of the easiest, least expensive tests to do. And I insist on it, even in gentlemen who have come and said, oh, no, I have 2 babies with someone else, or I've gotten 3 women pregnant before. Sperm change, as I had mentioned earlier, it takes 72 to 90 days to make sperm. So whatever happened to that guy in the 3 months before is what's going to come out in the semen analysis. So I rarely will even let the semen analysis go, because again, it's quick, it's easy, it's not expensive. I think we charge like $130 for it, and it gives you a ton of information. So semen analysis is really what we're going to be heading for next in our evaluation. So instructions for a semen analysis. Okay, you need to have 2 to 5 days of abstinence, because as I said earlier, over 5 days of abstinence, the sperm are dying. So you just don't want to give us a cup full of dead sperm. Now, one thing that is sometimes a misperception, is that if a guy ejaculates, he has sperm. That is not the case. I can have guys give me like 2 drops of ejaculate, and it's filled with 40 million sperm. Or I can have a guy like try to fill the cup and put in 3 or 4 cc's of ejaculate. And my med's was laughing. And literally 0 sperm. So just because a gentleman ejaculates does not mean that there's sperm in that ejaculate. We recommend that the samples are collected by masturbation, okay? You can't use lubricant, okay? Saliva kills sperm, lubricant can kill sperm. I had a couple when I first started practicing, and when we took their medical history, we asked everybody also if they're losing lubrication to have intercourse, and they were using KY, okay? Well, this was 20 years ago. KY was like the only lubricant out there at the time, okay? And KY has something in it called chlorhexidine. Well, chlorhexidine kills sperm, okay? So as a young couple, history was like, he's healthy, she's healthy, everything seemed fine. Why aren't they getting pregnant? Well, every time they had sex, they used KY, okay? So basically they came to me as a fertility doctor. I said, stop using KY. A month later, they were pregnant. I mean, so sometimes it's really simple, but it can also kill the sperm for a semen analysis. So if the patient needs lubricant, there is special lubricant out there that is fertility friendly now. It's called Pre-Seed, and it doesn't kill sperm, but that's only been on the market for like 15 years. So see how old I am. But it's, when I first started practicing again, there was no real options that you could just buy over the counter in your local CVS. You want to do at least one semen analysis. And if the semen analysis is abnormal, we never tell the guy that this is one and done, absolutely what happens. Because say he gives us a semen analysis, his levels are low, but 2 months ago, he had the flu. 2 months ago, he had COVID or something. I mean, and he had a fever and he was super duper sick. This could be transient. So I always recommend if we have an abnormality on the first semen analysis, this is not like the kiss of death so they'll never get pregnant or they're going to need in vitro or something like that. I say, look, let's wait 6 to 8 weeks. Let's repeat the semen analysis. And then let's see if this is a true correct, abnormality, or it's corrected itself because of time. And then if it is abnormal the second time, then we have them evaluated by a urologist, which would be a male doctor taking care of just gentlemen. And they have special ones now. And this is a new specialty. So if anybody's interested in urology, okay, there's a fellowship that you can do just in male fertility. So you go into urology, you don't have to do kidneys, you don't have to do bladder. You can actually do it's a subspecialty. Just like I am a gynecologist and I specialize in female reproduction. In urology now there is a fellowship that is just for male infertility. So it's a newer specialty. There's like a handful of these guys board certified in the US. Like it's a real up and coming field. And we have one in the entire state of Florida. So if anybody's interested in urology, it is kind of a cool field for you to look into as well. So when we look at sperm values, okay, we're looking to see, what is normal. So we got this guy and his semen analysis showed he had 2 cc's of volume, which 2 to 5 cc's is normal, okay, and of volume. His concentration, his pH was 8, his count was 31 million, motility was 64, morphology was 12% normal forms. So all he needed was basically 39 to 40 million to be normal. He was 31, so that's a little bit low, but they were moving. They were 64% modal. You only need 40% to be modal to be normal. And then his morphology, which is the look of the sperm. Let me just kind of show you guys. I didn't put this little sperm picture on there, but I love my little sperm picture of normal head, neck, and tail. So that's a sperm with a normal head, neck, and tail. These are all these funny looking sperm, and only 4% of your boys have to have a normal head, neck, and tail to be normal. This guy had 12%. So his counts are a little low. So this is definitely a consideration. Like maybe he's causing, maybe he's slowing them down getting pregnant. But his basic parameters on his motility and his morphology, they look pretty good. So now we have to determine that even though she has regular periods, okay, is she ovulating? Because, okay, just having regular periods does not mean you're ovulating. So how do we determine that she's ovulating? Well, the first way is we do it by just her menstrual history, okay? So we ask her what's her cycle length. Most ovulatory cycles are going to be within 21 to 35 days, with 28 days being kind of the average. If you're, some patients may say, oh, my cycles are irregular, but even if it's within 28 to 31, that's still considered regular. What irregular is going to be considered is, 45 days, 50 days, 60 days, I don't get periods for 3 months, I have no period for 6 months, then you probably can just ascertain that they're not ovulating. But the reason I talked to you about the menstrual cycle earlier, it's kind of my brick and mortar picture. So you can get menstrual cycles and not be ovulating, okay? And I have patients who have polycystic ovaries, and every month, menstrual cycle, menstrual cycle, menstrual cycle. Well, basically, their body is building up that brick wall. All the bricks are going on top of each other, okay, because the ovary is producing estrogen, but an egg never pops and ovulates. And so the brick wall builds up. There's no cement, there's no mortar holding it together. It falls out, okay? The next month, it builds up again. Brick wall gets crumbly, falls out. So these are called anovulatory cycles. So just a history of a regular menstrual cycle does not mean that you're actually ovulating, okay? So you can also ask them about their symptoms. Do they get breast tenderness, mood changes? I mean, these are also things like just ovulation. Some people will have that middle schmerz, which is like the pain when you feel with ovulation. I mean, some women come in here and they're like, oh, I'm absolutely ovulating. I feel it every month. It's the right month. It's going to be the right side this month. It's the left side last month. And usually the ovaries will alternate. So these are all just little clues that as we're kind of taking a history, like, do I think she's ovulatory, or, you know, do I think maybe she's not? I just had a lady the other day that she told me regular menstrual cycles. I go in and look at her ovaries and she's like 25 follicles on each ovary. I go, you don't ovulate. I'm like, that's your problem. She definitely has bad polycystic ovaries. The other way is we can do it with a little bit more scientific, and these ovulation predictor kits are available, and sometimes patients will come in and they'll tell us they've been using a kit already because they're easy, they're cheap, they're over the counter, you buy them at the drugstore. And so what this is detecting is that, you know, back to the menstrual cycle, is your LH surge. So your LH surge is going to be in your body for 18 to 24 hours, and you can detect the LH in urine. And they have these, you know, inexpensive kits that if you use your second morning urine and you pee on the stick, okay, and you get 2 lines, you get a little smiley face, okay, your surge is there. So this is the time to have intercourse. So sometimes the patient will come in and say, oh, I've been using ovulation predictor kits, and every single month they turn positive. Or they'll say, 1 month they're positive, 1 month they're negative. You know, I haven't gotten, you know, sometimes it happens, sometimes it doesn't. And then you're suspecting, you know, irregular ovulation. The best way to check is going to be with blood, okay? So we go back to that menstrual cycle diagram. And so that progesterone, remember I said, should peak 1 week after you ovulate. So that's what we draw in blood in our office, okay? Everybody here, we trigger your ovulation, or we know when you're ovulating, you come back in a week later, we check your progesterone level. So progesterone level greater than 3, okay, is going to be diagnostic of ovulation, okay? We want the level to be greater than 10. When you're in a non-medicated natural cycle, we want it greater than 15 if you're in a fertility treatment medicated cycle. But that's like your best, that's your best bet, okay? All the other stuff is like, you know, it's, you know, maybe she's ovulating, maybe she's not. Sometimes the kits are 80% effective, but sometimes they can lie to you. The other way we look for ovulation in our office, again, because I'm a fertility specialist, is vaginal ultrasound. So I use a vaginal ultrasound, we take a look at the ovary, we see the follicle, and then we know that a follicle is developing. So similar to that menstrual cycle picture, we see it on the ultrasound, and then sometimes we give people a trigger shot, and then we'll see it kind of collapse. Basal body temperature chart can also be used. And the reason that basal body temperature chart has been, you know, some people do it, they chart and they chart the temperatures. So what happens is that progesterone, okay, is what we call a thermogenic hormone, okay? It raises your body temperature. So prior to ovulation, as we saw on the initial chart, your progesterone is low, okay? So it's less than 3. So your temperature is going to be usually less than 98, less than 98, definitely less than 98.6. It should be running around 97, 97.6, and you have to check the temperature first thing in the morning. So you have the basal body temperature sitting by your nightstand. Before you get up and do anything, you stick the thermometer in your mouth, 97.6, you chart it. Now, after ovulation, okay, it's going to drive that progesterone up greater to your body temperature to be greater than 98.6. So, you know, I had a patient come in and she brings me these basal body temperature charts, and she hasn't gotten a period. She has a irregular cycle. So she shows me this. It has a flat, it's lower than 98 here, and then it drops a little bit, then it goes up and it's above 98. No, now her temperature has been above 98. Okay. I think on the chart that she showed me, it was for about 3 weeks, and she said she hadn't gotten a period. I basically looked at her and I go, you're pregnant. Okay. I mean, it was, she was pregnant. She just didn't realize she was pregnant. But if your temperature, because your temperature will drop after 12 to 14 days, because that's as long as the progesterone will stay in your body. So it's also kind of like a cheap way to see if you're pregnant. I actually used the basal body temperature chart when I had my, I think it was my first baby, I kept checking my temperatures. I'm like, oh my God, my temperature's been up for 14 days now. I said, maybe I'll have the courage to take a pregnancy test, and it was positive. But so again, it's a very cheap, inexpensive way to just kind of get an idea of where you are in your cycle. It's not useful for timing intercourse though, because the problem is once your body secretes progesterone, the deal is done. Okay, the cervical mucus is dried up, the egg is dead. So once you detect the temperature rise, it's like, all right, well, I can't get pregnant now. So that's the truth of the matter. So you can use it retrospectively. You look at page after page of these basal body temperature charts that sometimes patients would bring in, and you're like, all right, she's ovulatory that month, ovulatory that month. Sometimes you'll look at these pages and you'll see your temperature just down each month. It doesn't even go above 98. We're like, okay, we know your problem. You're not ovulating. But you can't use it to time intercourse because you're never sure when that drop is going to be and when until you see the rise. So we don't use really in our practice at all. I mean, we use ultrasound, we use blood, but when people are out there just trying on their own and trying to get the timing right and see what's going on with their bodies, it's something that you can use that's like super cheap because it's just a thermometer. So of our history in the female partner, did you put that one in again? We did that one already. We did that one already. No, we did that already. I don't know how that got in there. That wasn't supposed to be in there. All right. So the causes, if you have an irregular cycle, I've already talked about them a little bit. Polycystic ovaries, that's a syndrome. In that syndrome, there are 3 criteria. Okay. One of them is irregular cycles. The other one is hyperandrogenism, where the testosterone levels come in. And then the other is ultrasound appearance of more than 12 to 15 follicles on each ovary in ultrasound. So, but the testosterone levels, we may check those to see if polycystic ovaries could be a problem with the irregularity of the cycle. We also will check for something, we'll check as something called a 17-OHP, or so 17 hydroxyprogesterone, and that's to rule out a condition called CAH, or congenital adrenal hyperplasia. Super rare. I've had literally 2 cases in 20 years that's been the cause of the irregularity in the cycle. But still, we usually check it just to rule it out, because again, it could pass our way every once in a while. So you should rule out a 17-OHP. If again, the patient's irregular, and because it'll mimic a CAH picture, will mimic a polycystic ovary picture. They look identical until you get the 17-OHP. Thyroid dysfunction, that's also going to cause irregularity in your cycle. So we check TSHs on all of our patients to make sure that their thyroid is not underactive. So underactive thyroid will definitely cause ovulatory problems. Overactive thyroid sometimes does the same thing, but not as much. It's not. Overactive thyroid is much less common than underactive thyroid. As we mentioned before, prolactin levels. So TSH and prolactin are kind of gold standards to draw in a patient who has menstrual irregularities, because again, the pituitary gland could be putting out extra prolactin, and that would be indicated by sometimes we have galactorrhea or milk coming from the breast, but is easily treated with a prolactin lowering agent, and the patient becomes ovulatory again. Hypothalamic dysfunction, basically the brain shuts down. And then also we can check hormone levels to see whether they have early menopause, and that would be a high elevation in that FSH test. So normal FSH levels that we draw in the beginning of the cycle should be less than 15, preferably less than 10. If we get back an FSH level in someone who's trying to conceive and having irregular in their cycles, that's basically greater than 25, they're entering a perimenopausal or menopausal state, which is kind of scary because that's something we can't reverse. So ovarian testing, okay, that's the next thing that we're going to talk about, because a female is born, okay, with a set of gametes, okay, and maximum number, just slide here, move this down, this down, move this down, to play with these boxes here. I can exit out. Oh, I can exit out and how to go back to it. All right. So I can read my slide. So maximum number of eggs is 7 million when you're 7 months in utero. Okay. So you haven't even been born yet. Okay. And that's the max eggs you're going to have. By the time you're actually born, you only have 1 million eggs left. Now you figure if you only want 1 or 2 kids, 1 million eggs should be enough, right? By puberty, you're down to 300,000. Okay, still, if you only want 1 or 2 kids, 300,000 eggs should do it for you. By menopause, you're down to 0. So What happens is that your pool, okay, it declines with age, and it stays pretty fixed up until like age 32, 35. At 35 is when things start to go south, okay? So we see this in our pregnancy rates in just with our fertility treatments, like in vitro. 35, like I can get a 25-year-old pregnant pretty much as easily as I can get a 32-year-old pregnant. Their chances of pregnancy really don't change that much. However, once that patient turns 35, her success rates will drop by 10%. At 37, we'll lose another 10%. It'll drop again at 40. And then pretty much after the age of 42, we are no longer able to help women with the kind of medicine that I practice to have babies with their own eggs, okay? So the pregnancy rates, as you can see in this lower graph here, are just dismal. I mean, it's the only word for it. So this is why we encourage patients to, either freeze their eggs, okay? And anybody who's listening to this, who's pre-med, okay? If you're thinking about, we're talking about med school, residency, fellowship, all this stuff, okay? Try to get those eggs frozen before you're 30. I mean, if you have the means, I know it's a little expensive and everybody has student loans and stuff like that, but we get so wrapped up in our careers, okay? And this was actually personal, for me. So I knew I had my plan. I had my, mentorship, residency. I got married in the third year of residency. I plan to do a fellowship. Our fellowship is going to take 2 or 3 years. And then I'm like, by the time I'm like 35, 36, then we'll think about babies. Having fun, working hard, traveling, doing all sorts of stuff that I didn't think babies were an issue. When I hit that third year of residency in OBGYN and I did my fertility rotation, okay, the plan changed. Okay, the plan changed dramatically. And so I was planning on 36, 37. And after I saw girls that were younger than me in the fertility clinic with problems, I went home, I said to my husband to be, I'm like, remember the plan I had? He's like, well, you're going to be the fertility specialist. You just take care of it all. Okay. So I started trying to get pregnant in the first year of my fellowship, actually. And I took over a year. I needed to do fertility treatment to get pregnant with my first daughter. And I'm so glad I did, because I probably wouldn't have kids now if I had stayed with like plan A. Freezing eggs was not a possibility 22 years ago, but now it is. So I have already discussed with both of my daughters who are pursuing careers in medicine that, if they're not interested in having kids during their training or anything like that, mommy will be freezing your eggs when you're 25 or 26. Okay, they've been told that from a very young age that we'll be getting some eggs in the freezer. They never have to use them if they get pregnant easily. When they want to in their 30s. Eggs in girls in their 20s are very, very marketable. Okay, we are always looking for egg donors. You have to be a healthy female, don't drink, don't smoke, between the age of 21 and 30, and you can get anywhere between $8,000 to $12,000 for one round of egg freezing. For donating them, they'll pay you for them, and then some clinics you can get paid for donating one round of eggs. You can get paid for donating a second round of eggs. And then even in the third round of eggs, they'll actually give you half of your eggs for free. So you didn't have to pay the $10,000 to freeze them yourself. So it's a really nice option, I think, for medical students, pre-medical students who meet criteria, to actually pay back some loans and to get a little insurance for the future. Again, some people are scared of needles and stuff, but it's really not a scary process. It's quite easy when we walk people through it. So I have a question here, I'll just address it. Is there a way to determine if a female or male is infertile before they start trying to get pregnant, reduce the stress of fertility later? Yeah, there is actually. I think, let me see if that's on the next slide. Okay, yeah, so this is one of the tests that we do to kind of just get a handle on fertility. Not as good as the next test on the next slide. But an FSH test, okay, as I said, it needs to be less than 10 with an estrogen less than 50. So this is one test that we do check on patients. If it's greater than 20, that's concerning for menopause. And if it's greater than 10 or 11 with a higher estrogen level, it makes us suspicious that there might be some infertility problem with the egg reserve. This is the test, okay, that is all the rage. So I'm not sure whether anybody's kind of heard of it, but this is the test that there's these buses in New York, and there's these new venture startup companies that are out there that are advertising free AMH tests, like come freeze your eggs with us. So if somebody wants to find out, especially a woman, okay, wants to find out where she stands as far as her fertility, this is the test you need, okay? It is just a blood test. It can be drawn by any time in the menstrual cycle. This is a hormone that's produced in the granulosa cells of the follicles, okay? And what it reflects is your egg reserve or your egg pool, okay? I have this huge chart in my office, okay? That I don't know if you can see it, okay? Then this is your egg pool when you're young in your 20s, and then it just dies off as you get into your 40s. But it is a easy, inexpensive blood test that can give you a snapshot of what your fertility looks like. Okay, so for females, that is going to be the best way. And guys, you just need a semen analysis. And a semen analysis, again, $130, super cheap, super easy, regular labs, Quest LabCorp will do just to tell you whether you have sperm. And interestingly, okay, and I learned these things from patients, okay, you can buy sperm kits on the internet, okay? And what the sperm kit does, have you seen this? You give a sperm kit and you actually put the sample on it, and then you stick this slide into your phone, and it'll show you a picture of whether there's sperm, and it'll assess your own sperm at home. I mean, I think it's like $80 on Amazon. I have patients who do this. You can buy this at-home sperm test. So that gives a guy, just without even coming to a fertility clinic, I mean, you can check them on Amazon. AMH level, you kind of need a lab for that. I don't think you can get an AMH test on Amazon. But so again, sperm analysis is the first thing to tell if a guy is having any issues with his sperm. And then the AMH test, which is anti-Mullerian hormone. A test that a doctor has to do, particularly a fertility specialist, would be an ultrasound. So an ultrasound, what we look for is something called an antral follicle count. So basically, I put an ultrasound in, I take a look at your uterus, I take a look at your ovaries, and I just look, are there little eggs on it? The little black circles, are there eggs on it? And we'd like to see at certain ages, different numbers of eggs are normal. As I said, in the polycystic patient, they have 12 to 15 eggs, but that's excessive. We just want to see anywhere between 5 and 10 follicles if someone is in their 20s or in their early 30s. And then as you get older, okay, the number of eggs we're going to see on the ovary is going to decline on ultrasound. But that's also, it's a little bit more invasive way to do it. But this AMH blood test is really good. The situation that we come into sometimes, and I've had this happen to me, we have a patient comes in, she's 24 years old. She wants to be an egg donor, okay? All right, great. It's one girl. She was bartending as a job, and she was also a driver for some guy. She's 24 years old. She moved down to Florida from Ohio. Comes in, she's healthy, and she wants to donate her eggs. Okay, so here we draw an AMH on her. That's why we screen our egg donors before we start to spend any money on genetics or anything else. We get back an AMH. Now, when you're 24, your AMH level should be 4 or 5. Okay, that's the normal level. This girl comes back at 0.4. Like, what do you tell her? Like, number one, she can't be an egg donor. And number two, don't wait to have your kids. But and she's obviously in no position to have children at age 24. She's just kind of hanging out in Florida for fun. She, has no means because she's trying to make money, selling her eggs. And now you're telling her you should freeze your eggs yourself because you're going to be out of eggs. I mean, you don't know when you have an AMH level that low and someone that young, whether they're going to even be able to get pregnant in their 30s. I mean, it's very, very, very scary. So that's why the AMH test, I think, is a great test. Most gynecologists, unless they've actually been fertility patients themselves, are not super familiar with it. So it may be a test that you have to push for a regular gynecologist to get. I mean, every fertility specialist does it on the first visit. I mean, it's our go-to test. But the gynecologist can draw it, and it can go to a commercial lab. Just a question: how invasive is the process for freezing your eggs? So freezing eggs is not bad. I mean, it's not bad. It's basically 2 weeks of work. Okay, so there's preliminary blood and ultrasound that we do just to make sure that the thyroid's good, the prolactin's good, everything's healthy, and then you get a calendar. And the calendar basically says we're going to start hormone injections on this day. Now, we put patients on birth control pills before we start the hormone injections, okay, just so we can time it. So they know, hey, I'm going to be taking injections this first week of March, the second week in March, and my egg retrieval is going to be, say, March 12th. So what it involves is 2 weeks of your life, okay, where you do injections for 3 days, you do blood work and ultrasound. Injections for 2 days, blood work and ultrasound. Injections for 1 day, blood work and ultrasound. So it's going to be about 6 or 7 visits to a fertility clinic while they watch your follicles grow. While we're watching your follicles grow, we watch your estrogen levels go up. Okay, we want your estrogen levels and your follicles to kind of grow together. As they're getting bigger, your estrogen should get higher. At the end, when the follicles are ready, which is they're going to be measuring 18, 19, 20 millimeters, they should have mature eggs in them. You'll get a final trigger shot. The trigger shot will get your eggs to mature. 35 hours later, you come into our clinic. We give you an IV. We give you a little bit of medicine called Versed to relax you, like a martini. We give you some propofol to put you to sleep, and we give you a little bit of fentanyl to take the edge off any discomfort. It takes me 10 minutes to take out eggs. I take out the eggs, okay? The lab gets the eggs. They look for the mature ones. They freeze them 2 hours after I take them out. You are done an hour later. You recover from the anesthesia, usually fine that night. You go back to, get back to eating regular and everything. Next day, you can go back to work. Usually you're bloated for about 3 days after the egg retrieval, but you get a regular period. 7 days later, your ovaries deflate, you're back to normal. And then we discuss how many eggs that you retrieved, whether you'd want to do it again. So people with poor hormone levels may have to retrieve their eggs a couple of times. Sometimes from donors, we can get 40 to 50 eggs in one shot. So again, it's not a bad procedure to freeze eggs. It's just kind of, it's 2 weeks of just a lot of visits to see the doctor. But AMH level is just a great test that I would encourage any pre-med, especially medical students, to get done, just so you have kind of that cognitive assessment of where your fertility stands. All right, so the next test we're going to move on to after we check the sperm, we check the eggs, is going to be patency of the fallopian tube. So how do we do that? So, or why would we suspect that the tubes might not be patent? So if somebody gets PID, okay, high incidence of damage to the fallopian tube. So if somebody gives me a history that they've had chlamydia or they've had gonorrhea, there is very high risk for having blocked tubes, because these chlamydia, especially chlamydia, it's very insidious. So a lot of people will have chlamydia and never knew they had it. So we can actually draw a blood test to see if you have antibodies against chlamydia. So I'll get sometimes blood tests back, and a patient will say they have high chlamydia antibody titers. And you ask the patient, you ever have chlamydia? And they're like, no. I'm like, uh-oh. Because that means if they didn't know they had it, they weren't treated for it. And chlamydia can just wreak its havoc in your pelvis if you didn't know you had it. So that's why the gynecologist routinely will screen for this. Because if they know you have it, if you treat it early, it may not damage your fallopian tubes. The other thing you want to ask patients again about is peritonitis, if they had any type of, infection inside their belly. Ruptured appendix is numero uno. That is number one problem. If so, anybody has an appendectomy, I say, hey, was it ruptured? And they say, oh no, they caught it in time. Or they say, oh no, it was ruptured, and I had to stay in the hospital for a couple of days on antibiotics. So ruptured appendix, basically what happens is when the appendix gets infected and it bursts, it just causes yuck into the belly, which causes this yellow pussy stuff. It's really gross. And the yellow pussy stuff, when the body reabsorbs it, okay, actually will cause this webby like scar tissue, okay, and it will particularly, it will damage fallopian tubes. It'll kill the fingers, or what we call fimbria on the end of the tube, and again, very high risk of infertility after a ruptured appendix. If you've had any prior pelvic surgery, like a myomectomy, which myoma is your fibroids, and we've taken out lesion in the uterus, or if you have a history of endometriosis or a family history of endometriosis. Endometriosis is an immunologic disease that causes inflammation inside the belly, and it does run in families. So if I have a patient who says the mom had endometriosis or hysterectomy for endometriosis, it's very likely that endometriosis is the cause of that girl's, probably a factor in her fertility issues. So what's the test? So there's a couple ways to evaluate tubes. So the easiest non-invasive way to evaluate tubes, okay, is going to be with something called a hysterosalpingogram, or HSG. It's basically done under fluoroscopy. So in 3 of our offices, we have 6 offices, but in 3 of our offices, we have what we call C-arm. So we have a radiologic device that we can do these x-rays in our office. So we do sequential x-rays, okay, as we're putting contrast media into the uterus, okay. We put a catheter in the cervix, okay, some dye goes into the uterus, and then it comes out the fallopian tubes. Bingo, results right away. We use, there's oil-based options. They're really not available in the United States. We use a water-based low iodine concentration dye because we can see it on the x-ray. So super easy. It's a 5-minute test, not very painful. Some people get cramps, but it's very well tolerated. The other way to look at tubes is going to be to do surgery. Okay, so that's a laparoscopy. That's a surgery. We put a little incision in your belly button, put a camera in, and then we put blue dye. through the fallopian tubes, and we see blue flow out the fallopian tubes at the time of surgery. We can also do what we call a saline sonogram or a water ultrasound, and we can mix fluid and air in a syringe, put it into the uterus through a catheter, and then on ultrasound, we can see the white air bubbles and we can see them flow out the fallopian tube, okay? And then this chlamydia antibody test that I mentioned before, it can also be used as a screening tool. So again, if you have IgG antibodies in your blood, it does indicate you had chlamydia even though you didn't know you had chlamydia. So these are just something that's the screening tool. Oops, okay, there we go. All right, so this is what an X-ray looks like, okay? So this is a normal X-ray here. This is the uterus. The uterus is only 3 to 5 cc's big. It only has 3 to 5 cc's of liquid can go into it. So it's a teeny little cavity, okay? This is just the inside of the cavity. And then these little things out here are the fallopian tubes. So we have a little line here, line here, line here, and here goes dye out the fallopian tubes. And this white stuff here is the dye spilling. That's the left tube. This is the right tube over here. Same thing, the dye fills in the tube, and this is the dye coming out. Again, I did 3 of these today. So this is something that my medical students probably I don't know, probably do at least, I don't know, probably 25 or 30 a month. Most of them are nice and normal. However, this is an abnormal, okay? So this is the right fallopian tube. This is swollen. This is what we call a hydrosalpinx, okay? And this is a hydrosalpinx here. These are bilateral hydrosalpinges, and this is not good. So this young lady is going to need in vitro. They're very severe things. So in our couple, we're going to evaluate the patency of her tubes and her uterus, sorry. Well, her uterus, we can also do it with the hysterosalpingogram, the saline sonogram, or we can put a scope in the uterus. We can do 3D ultrasounds to look for anomalies of the uterus. Other methods, we do biopsies of the uterus, looking to see if there's infection or any type of problems in the uterus. So biopsies are something we do commonly too. I think I missed a slide there, but I'll find it. So again, tubes, uterus. Uterus, again, ultrasound, that's the key. The gold standard for uterine evaluation is hysteroscopy, which is a minor surgery putting a scope in the uterus. All right, so that's our case. Okay, so our case, we're talking about, the 33-year-old male, but anyway, he was 33, I think she was 29, but I got the ages wrong here. Anyway, she had regular cycles, no STDs, but did have that ruptured appendix. Husband has basically a normal semen analysis and unremarkable history, okay? She is having positives, so this is the little ovulation predictor kit. You get the 2 lines. On there, you get the smiley face. So she's probably ovulating, making the luteinizing hormone, which is making her kit positive. However, here is her X-ray. So on her X-ray, what happened was, this is her uterus. Here is her fallopian tube on the left, and here is her fallopian tube on the right. Okay, so the right fallopian tube is blocked and it is filled with fluid, most likely from her ruptured appendix. So this is definitely high on our differential diagnosis, as this is what's causing her infertility. Okay, so we have to kind of tailor, your underlying etiology for the infertility. So we've already talked about a bunch of this, is correcting the thyroid, the prolactin. If they do have ovulatory dysfunction, we can use fertility medicines like Clomid or letrozole to help them ovulate, monitor treatment for response with an ovulation kit or ultrasound. If you're not pregnant with the fertility pills in 3 or 4 cycles, we have to reevaluate you. We can expand your diagnostic evaluation, change treatment strategy, and then this is just for general OBs. But if you've done all this for the patient, then you refer them to me. So sometimes patients have had this basic evaluation done before they come to me. Sometimes I start with this stuff. So managing fertility. So if you have diminished ovarian reserve, okay, so the partner's over 37, you've got FSH elevations, okay, I should be seeing them, okay? So the general OBGYN should send them to me, okay? And that's the kind of patients that I see. Sometimes I diagnose them with this and we get more aggressive. If there is tubal disease noted, you could consider repair, but tubes don't repair well. You'd want to do surgery. And that is what we would do for our couple. If any doctors out there see blocked tubes, I think most of them are educated enough now to remove the tubes if they're damaged, because fixing tubes that are swollen on the end, it just doesn't work. It's really an exercise in futility, and years years ago, back in the early part of my career, we did not know that the fluid in the tube was toxic to the inside of the uterus. So we would try and repair the tubes. We do a little surgery and microsurgery and try and fix the tubes back, but they all closed up again. And then there was a mouse study that was done in 2002. And the mouse study showed that if you left blocked tubes in and you did in vitro, the mice got pregnant at half the success rate. So after 2002, the recommendation has been if the tubes are blocked, like in the picture I showed you, they should just be removed at surgery. If they're damaged, they're not going to do the patient any good. Uterus, again, fix anything. If it's a fibroid polyp, anything in there, you can fix it surgically. Male should go to a male fertility specialist. IUI is what we use as far as treatment for guys, okay? And then severe sperm abnormalities, if the guy doesn't have enough sperm, we'll have to do in vitro with them. So IUI and IVF is pretty much what I do, like most of the time. If the semen parameters are borderline, I can do IUI, which means I wash the sperm and I put it into the uterus. If there is severe abnormalities and the guy just has like, he doesn't have 40 million sperm, he only has say 100 sperm, like that's it. We'll have to do what we call ICSI, which is where we take an egg and take a sperm and inject it directly into the egg. Unexplained, okay, infertility is something that we see a lot. As I said earlier, we talked about the causes of infertility. 15% of our patients, we're going to work them up and everything's going to be fine. Okay, there's going to be no abnormalities. And so if they're failing to conceive, we just do what we call empiric treatment. Okay, where we will just try to make everything better. We'll make you ovulate better. We'll stick more sperm in there. And after a couple tries, if we don't get you pregnant by making your ovulation better, by making your exposure to sperm better, you'll need to move on to IVF. These are just some of the drugs that we use. We use Clomid, we use letrozole. Sometimes we'll use metformin in patients with polycystic ovaries. And again, if you have that CAH, which again, I saw twice in 20 years, actually the treatment is glucocorticoids, some steroids to improve ovulatory function. Surgery for infertility, we don't do much of this anymore, okay? I did when I was a fellow, which was like super fun fellowship. I had the best fellowship ever. I did 500 surgical cases in 2 years. I mean, it was like fertility when I was training, surgery was the mainstay of what we do. Now, the mainstay of what I do is sit in the office, talk to people, and walk across the hall and retrieve eggs and make embryos and walk across the hall and transfer embryos. That's pretty much what I do all day. The only little surgeries I do is I take out little polyps, I take out little fibroids, I take out blocked tubes, but that's it. Every once in a while, I'll do a surgery to remove endometriosis. In a specific case, but as of 2010, the recommendation used to be prior to 2010 that everybody who's undergoing infertility evaluation get a laparoscopy to check for endometriosis. After 2010, they said, stop operating on people, you're wasting their time, just do in vitro. So I don't do a whole lot of endometriosis surgery anymore. However, it is one of the reasons that I went into this specialty was because I'm a surgeon. I love doing surgeries. They were super fun. There was a lot of them, but the whole reproductive endocrine world has moved away from surgery, into assisted reproduction. So if you're thinking about, OB and you like surgery, there are new cool fellowships you can do on what we call micro-invasive surgery. So I have a friend right now, she just finished her residency and she's doing another year of what we call micro-invasive surgery with the robot. And she just wants to go into regular private practice in OBGYN. But she's doing that because she wants to just really get stronger with her surgical skills. So in OB also right now, it's really interesting. They're also getting surgical specialties of just hospitalists, okay? So there's some OBGYNs that don't even do surgery. They don't even do anything in the clinic. All they do is a hospitalist. They just deliver babies. So they stay on the hospital floor. They do shift work. So the subspecialty of OB has kind of changed into people who really gravitate towards surgery, people gravitate towards obstetrics, and then you have the subspecialties like me, and our specialty has even changed a lot. So let's see, why is the uterus off to the side in the scan? Oh, uteruses can be like so normally the uterus is in the middle, but sometimes they're tipped this way, sometimes they're tipped backwards. I mean, that's actually pretty normal. The uterus kind of moves around. It's on ligaments that can move it around. So, and the blockage of the tube, yeah, that's definitely from the ruptured appendix. I mean, that 1000%, because it's interesting when you see ruptured appendices, it's only on one side. Okay, so it gets blocked on one side, but the pus affected that side of the body, and it didn't leak over into the left tube and damage the left tube. And so what happens is that you have the fluid, okay, in the tube, which is toxic to the uterus. So sometimes I'll go into surgery, I'll just take out that right tube, patient will get pregnant from the left, because the toxicity of the fluid in the tube was just poisoning the inside of the uterus. And then once you took it out, the patient had no problems getting pregnant. So I've done that multiple times in my career. We don't take out polyps laparoscopically. We take them out hysteroscopically. So it's my little uterus here. So the little polyps are inside the uterus. So we put a scope right inside the uterus, and the uterine cavity is like that big, and fluid circulates around in the uterus. We put a little electric knife up to the polyp, zoop, we take it out about 10 seconds. So that's about a 10-minute procedure. So we take out laparoscopically, we take out tubes laparoscopically, we take out fibers laparoscopically, we treat endometriosis laparoscopically, and that's again through the belly. The hysteroscope is just through the vagina, so there's no cuts there. How often do I conduct surgery? I do. My surgical repertoire is very, very, very limited, because everything in my specialty that we do now is all in preparation for IVF treatment. Okay, so if there's a polyp in the uterus, I do those. I did about 100 of those last year. If there's a fibroid inside the uterus, which is going to be like this little ball, like inside the uterus, a little white thing there, that is going to impact implantation. That's my favorite surgery. So I take that. I'll take out fibroids. I've done tons and tons of those. I do probably 25 every year. And then I will also take out septa. Septum is a little piece of tissue in the middle of the uterus, and we just cut it down with a little scissor because it can lead to miscarriage. So they're my three surgeries that I do hysteroscopically. And then laparoscopically, I take out fallopian tubes, and I do surgery for endometriosis. That's kind of the mainstay of a fertility surgeon, but we used to do, again, lots of diagnostic, just looking for things when people didn't get pregnant, but we don't do that really anymore because it's not recommended. I operate, I usually do about 2 or 3 cases a half day every week on a Monday. So I do about 3 cases a week in general. But surgery, I love surgery, it's fun. But when I was, again, years ago, I was doing, oh my gosh, probably maybe 6 cases a week or more. But it's not the mainstay of what we do. Okay. So in the case, basically what happened, the diagnosis, it was, again, tubal factor with unilateral distal obstruction, okay? Laparoscopy was going to be the treatment. And, you know, what happened was that we took out the block tube, left the open tube in there, and then see if the patient gets pregnant. So this is like a surgical picture here. So this is an ovary here, and this is like a healthy ovary. This is the fallopian tube here. This is the healthy fimbria. They look like, when you put them, it's really cool. When you put the fimbria in water, okay. Oops, who's that? I'm good, okay. When you put the fimbria in water, they float and they look like feathers. I mean, they just look like little feathers. It's really cool. And feathery fimbria is what's used to pick up the eggs. So the tube and the ovary in this picture here, they have great proximity. So this is where it ovulates, and this is how these little feathers like pick up your egg, and that's how it goes into your fallopian tube, and it gets fertilized like right in there. This is a sickly tube here. So this is a tube that's like, it's all dilated. We put this blue dye in, and this is the fallopian tube that's blocked, swollen, healthy with the fluid trapped inside. And so basically we come across right here with a little bit of cautery. We go down along here, which is called the mesosalpinx. We just cut. And then it's like the tube is like a little worm. And I can take that tube out of a 5mm incision, because once the fluid deflates, you just kind of like, we kind of pull it out through the little laparoscopic trocar, like a little, it comes out looking like a little worm. But so I can take that tube out through very, very tiny little incisions. It's a fun little surgery. All right, so just additional management points. You always counsel the patients like we do, again, to try and maximize natural fertility. So intercourse, you know, every 1 to 2 days when you're ovulating, intercourse 2 to 3 times weekly, nearly equivalent rates, as I said, because sperm live long. So, you know, as long as there's some sperm around all the time, if you patient ovulates, she's more likely to get pregnant. We have to, you know, we try and educate patients on when their fertile window is. And make sure, again, if they're using ovulation predictor kits, that they're using them correctly, make sure they're working for them. As I said earlier, avoid lubricant. Some lubricants can be spermicide. Pre-seed is the one on the market. You can use olive oil and egg white. Sounds a little gross, but actually egg white is very friendly to sperm. Because we use this. I mean, before pre-seed existed, you had to tell the patient what to do. So olive oil can be friendly to sperm, and you don't use the yolky part, but you can actually use egg white, and it doesn't hurt sperm if you need a little, it's true. My medical students laughing at me, but it was something that we told patients before products were available, just to buy in a bottle. You want to try to get everyone healthy weight. You want to look at their diet, their exercise, because again, this obesity epidemic. Is we don't do patients in our office. We won't take them through IVF with a BMI greater than 35. Okay, so if your BMI is between 35 and 40, I just saw a lady today, partner got pregnant with IVF, lost her uterus due to an abnormal placental attachment, same-sex couple, and she has one more embryo left. Well, her female partner wants to carry that embryo, or female partner's BMI is 38. So anyway, we have to have her female partner lose a little weight before I'll put back in her embryo, because you do have a higher miscarriage rate if your BMI is over 35 and you do in vitro. All right, so let's see. Once you take out one tube, does the ovary that remains? Yeah, no, it doesn't affect the ovary at all. So the tube's gone, ovary just keeps working, just keeps working. Now, unfortunately, the eggs don't have anywhere to go, but the ovaries come from germ cells. Okay, and the tubes and the uterus come from mammalian cells. So the ovaries are completely different. They have nothing to do with each other, and the tube and the ovary don't affect each other's function. So the ovary will just keep ovulating. It'll ovulate, but without a tube, it has nowhere to go. It just dies off. Eggs are microscopic, so it's a bummer that you waste those eggs. But as long as the tube on the other side. So usually those patients, unfortunately, only have like 6 months in a year to get pregnant, because it's every other month that your ovaries will usually ovulate, which is sometimes why we use fertility medicine to try to get both those ovaries to make eggs, so the patient has a better chance. All right, so in summary, okay, infertility is common, especially in my world, and it can result from many causes. Infertility evaluations to start with a good medical history, physical exam of both partners. I mean, it's kind of like the fertility specialist. I'm kind of like a detective. Okay, so I mean, I used to love reading mystery novels when I was young, but again, you're just trying to like put these pieces together, because I sit here every single day and I take the history and I do the exam. I'm thinking, what could be wrong with these people? And you just keep going through them, and then you start ordering tests. So you check the sperm test, you check ovulation, you check their tubes, you check their egg reserve, you check the uterus, you check the guy, and sometimes you still come up with nothing. But it's like a hunt, it's like a quest to find out what is wrong with these people. Treatment plan could be developed based on the basic evaluation. We can kind of like give them an idea of what they might need. I mean, again, fertility pills are our mainstay, and then IVF is our big treatment that works the best. But again, all couples should be counseled about maximum fertility. I just had a patient the other day. I was telling her, we were trying to find out when she got pregnant, and she actually had ovulated the day that I saw her in the office, and I didn't see the follicle, and she just did her ultrasound the other day, and she's pregnant. But that was just encouraging words from me, no treatment. And then again, they should be aware of their prognosis, with age being the biggest thing. So we saw a patient yesterday. Okay, I saw her in 2017. Okay, and now it's 2021, and now she's ready to do treatment. What have you been doing for 4 years? Okay, she was 37, and I had a great chance of getting her pregnant. Now she's 41, and it's like, we'll try, but it's like, where have you been for 4 years? So this is something I cannot stress enough, that patients, should not wait. All right, so let's do some questions here, because I'm almost done. Is that BMI limit only for females trying to get pregnant, or the male partner? So same deal, okay? We have a BMI limit in our clinic. I mean, 35, we're pretty strict on this. And we have like the fertility police. We have the fertility, there's 12 doctors. So it's like, somebody catches wind, oh, you're putting her through with a BMI of 37. They won't let us do it. If the patient has to show some effort to lose weight, because we know her pregnancy is going to be healthier. So some clinics do not have fertility cutoffs, like we do, but because we know we want the patient to have a healthy pregnancy. Okay, so we have 2 lifestyle coaches who will go through dietary lifestyle changes. We'll help patients lose body fat. We'll give them healthy dietary options. So we do lots of lifestyle focus in our practice, along with the fertility medicine. So just because you come to me and you have IVF IVF coverage and you want to start a treatment cycle, doesn't mean it's a good idea. So there's lots of stuff that we do. So other clinics don't do that. Sometimes they just take them through, a treatment cycle because, hey, the insurance says I can do it, let's do it. But sometimes it's not a good idea because we want it to work. It really is a struggle and emotional and difficult for patients to go through this type of treatment. And so because of that, we want it to work. So, and then for males, we really don't have a cutoff for males. However, we do assess the male health because overweight men, okay, again, as I said earlier, fat produces estrone, which is a type of estrogen. Estrogen is going to suppress testicular function. So it is very common for the obese male to have very poor sperm. Whereas losing weight in the male, we encourage it as long as the gentleman can give us sperm and an ejaculate. We usually can use it to fertilize his wife's eggs. However, when we have an obese male, we're going to be thinking that his sperm might not be looking that good. And we see that over and over again. So weight loss in a guy can also improve testicular function. If lifestyle changes are made prior to trying to conceive, does this help your chances? Oh my gosh, yes, like dramatically. Now, I do have a terrible story about a gentleman who I had last year who, guy comes in, sees me, okay, 6'2", nice looking guy, rugby player, like healthy. Get his sperm back. He's got like less than 1 million sperm, like really super poor. Bring him back in, ask him about, his lifestyle. Interestingly, he was a severely overweight, obese teenager. Okay. So, and there's studies that there's a study that showed that this is true. If you have severe obesity as a teenager, it stunts your testicular development. Okay, so this was something that was irreversible. His obesity in childhood, I do not think his testicles, no matter what medicine or anything we give him, are gonna wake up and work. Okay, because they never developed properly because of the obesity as a child. Now, marijuana and alcohol, okay, on the other hand, okay, we just had, I had a guy who stopped vaping, had DNA fragmentation in his sperm, poor sperm count, stopped vaping. 3 months later, his sperm looked like a rose. His DNA fragmentation is gone. His sperm count is up. It's like amazing. So that's the cool thing about sperm, is that if it's an insult like marijuana, alcohol, tobacco, a medicine someone's taking, if you stop doing it, most of the time the sperm will recover in 3 months. So it's not permanent damage. Sometimes obesity in childhood, again, and especially undescended testicles. Like if your testicles were not pulled down, early enough when you were a baby. I had one poor guy who his testicles, he said he was in Australia and his parents had his testicles pulled down because they were stuck in his groin and hernia sacs at age 12. And the surgeon told him his testicles will be fine. No sperm. Terrible. The poor guy was crying in my office when I told him that there was like no chance he was going to have sperm. So there are some things that happen that are not reversible, but if it's something like, just weight that was put on later in life and something that you're doing, yeah, we can, that can be helped. Let's see here. BMI, how does hyperthyroidism? So hyperthyroidism, it doesn't affect infertility. It doesn't really cause ovulation problems as much as hypothyroidism, okay? But hyperthyroidism is a problem in pregnancy, and it's also a problem to treat. So if you're hyperthyroid, what can happen to you have to kind of ablate the thyroid and ablate whatever is making all that thyroid hormone. And you can take a medicine called I-131, which is radioactive. And you have to, it takes about a year to get that radioactivity out of your body. So that's how it can affect fertility, because you shouldn't get pregnant after you take that. Or sometimes you can have surgery. But hypothyroid causes ovulatory dysfunction, not as much hyper. Hyper is a problem with pregnancy. It causes poor placental development. It causes intrauterine growth restriction of the pregnancy. So it's more of a problem to treat because there's only like one safe medicine to treat with it in pregnancy. So it's not a huge problem. It's manageable, but we don't see it that much, thank goodness. But it does lead to increased complications. Not as much again with infertility picture. What does the probability of birth defects increase the older the female? Okay, so let's talk about birth defects and chromosomal abnormalities. So a birth defect is basically a malformation. It means like you have a hole in your heart, or you have your intestines born outside, or you have a hole in your and the hole in the spine or spina bifida, things like that. That's a birth defect. Okay. So birth defects are usually something that has to do with nutritional status. So if somebody is deficient in folic acid and they get pregnant, the neural tube will not form properly. That's a birth defect. And that can happen at any age, whether you're 25 or you're 45. Okay. When we're talking about females and age, chromosomes are the problem. So sperm have 23 chromosomes, eggs start off with 46. So eggs, as they're going through that maturation process, 46 chromosomes have to line up, 23 chromosomes have to split at the same time, and 23 chromosomes have to leave the egg, leaving 23 chromosomes behind. 23, okay, 46 chromosomes. Okay, so as we age, things start to break down. It's like wrinkles and gray hair. Mitochondria are the little engines inside your cells, okay, that are going to drive the chromosomes to split, okay? So as we get older, your mitochondria get weaker, and therefore, sometimes your chromosomes don't split right. And if it leaves an extra chromosome behind, like Down syndrome is an extra chromosome 21. So an egg had 2 copies of 21. The sperm came in with their 23 chromosomes. Now we've got 47 chromosomes in the embryo, and the extra one is the 21, leading to Down syndrome, okay? The incidence of Down syndrome in someone who's 25 is 1 in 880. The incidence of Down syndrome in someone who's 45 is 1 in 12. So that's the dramatic effect that age has on the health of the eggs. Even though you have eggs, they are unhealthier. They are not as healthy as they are when you're young because the chromosomes don't split properly, and it's just a part of the aging process. Everything described seems very costly to have such for low-income families who need help with fertility. Get a job, okay, for somebody who covers fertility services, or live in a state that covers fertility services. So there's 15 states, not Florida, but there's 15 states in the United States, okay, that have mandated fertility coverage, okay? As long as you work for a company, I think it's greater than 100 employees or something like that. So 15 states, like if you live in Massachusetts, you got 4 cycles of IVF coverage. You live in New Jersey, you got 4 cycles of IVF coverage. You live in Illinois, you got 4 cycles of IVF coverage. So, or you can work for a large employer that provides those benefits. In our state, we do about 40%, maybe 50% insurance now. It's getting more and more. We're getting more and more coverage. For all teachers in Broward County have 3 cycles of IVF, which is wonderful, wonderful for them. So again, look for an employer that has coverage. Again, live in a state that has coverage. They're my suggestions. There are grants out there for fertility that people can get. There's different organizations out there. The Cade Foundation is one that will offer different things for fertility. How does Plan B affect infertility? Okay, Plan B has nothing to do with. Plan B is just like changing the lining of your uterus, so just in case an egg and a sperm found each other. Okay, it's trying to make Plan B makes the lining of your uterus less receptive to the embryo. So basically, it screws up the lining, it messes up the bed. It takes the so I said the estrogen, the progesterone, nice thick bed, nice sheets, they're nice made beds. The embryo's a plastic implant. Plan B just scrambles up the sheets, just messes them up so the embryo can't stick. Okay, that's the idea, but it doesn't affect your fertility in the long run at all. Like it doesn't affect it at all. Can you elaborate how marijuana affects fertility? DNA fragmentation. Okay, so even though a guy has great sperm, okay, normal semen analysis, when we do DNA analysis on marijuana smokers, they have high what we call DFI or DNA fragmentation index. And so what happens is, and this was a study that was published probably 6 months ago or maybe more, and they looked at 1,500 women. Okay, so these 1,500 women, they were all pregnant, and they gave them questionnaires and they asked them, does your partner smoke pot? All right, so the majority said no. Okay, so that's our control group. Okay, then there was a couple hundred women that says, yes, my partner smokes pot less than once a week. And then they had about 100 patients that said, yes, my partner smokes pot more than once a week. Okay, they followed those women and they looked at the miscarriage rate. The miscarriage rate was twice as much in the women who did not smoke pot, but their partners smoked more than once a week, implicating that there was higher DNA fragmentation in the sperm, and it carried over into the pregnancy, and the pregnancy was not strong enough to grow because the half of it is sperm and there was something just messed up in that DNA. And we think that marijuana affects that. We definitely know that marijuana slows down sperm. So where, you're high, you're feeling high, we see sperm that the motility is just super slow. I've had gentlemen who've chronically smoked marijuana for years and years and years, and their sperm counts are not recoverable. They're, million sperm. We have to do IVF. And sometimes we can't even do IVF because the motility is so slow. So long-term effects of marijuana, I've seen dramatic effect on sperm. However, we have to remember this, it is to the genetically susceptible individual. Okay. So what I mean by that is that, hey, some people can smoke pot every day and, have 16 kids. They were just genetically superior. It's kind of like skin cancer. So I'm Northern European. Okay. I can get a melanoma and I don't even need to get suntan. I mean, that's just my genetic makeup. I'm predisposed towards melanoma just because of my, background. Now, you can get a Greek, an Italian, a Middle Eastern person, they go out and bake in the sun and they'll never get a melanoma. So it's the same thing with really marijuana. It will affect some gentlemen dramatically, okay, and really cause dramatic changes in their sperm count. And it can even affect some gentlemen if they have a normal sperm count in their DNA. And we are just seeing it more and more and more with the legalization of marijuana. So we don't have great data yet, but it's coming. I mean, it's coming, saying that this is something that if you're trying to get pregnant, you probably shouldn't be doing. Yes, and the DNA fragmentation happens in the eggs as well. Absolutely. We're getting more and more data out as far as women. And even though, again, not a popular opinion, I mean, there's this stuff on the internet. It's like, oh no, smoke marijuana in your early pregnancy for nausea and vomiting. Like, really? There was a study that I just sent to somebody on Instagram that looked at the psychological development of the offspring of women who admitted to smoking pot throughout their pregnancy, and they're not normal. Like, there's definitely differences in when you care for women who smoke pot during the pregnancy and people who didn't smoke pot during the pregnancy. And the same thing happens with eggs. As far as does the DNA fragmentation happen to eggs? It does. I mean, I had a patient, okay, and I couldn't believe this. And again, it's just like our mindset with lifestyle we do beforehand. Patient comes here, so I say to her, so what can I do today? What can I do for your day? And she says to me, she's like, I have to be here. I'm like, well, you don't have to be here. This is all elective, okay? Like, you really don't. And I'm like, all right, well, why do you have to be here? Well, the center I was with, they lost their center of excellence, and my insurance tells me that you're the center of excellence and I have to come to your clinic. Okay, fine. So what happened? She had done an IVF cycle with the prior clinic, retrieved like 13 eggs, everything died in the dishes. Like, nothing even made it to freeze or transfer or anything. So I'm going through a history, okay? I go through history and it's like, all right, do you drink? Do you smoke? Yes. Okay, well, which one? I drink. Okay, well, how often? Okay, every couple of days. Okay, well, that's not that terrible. We don't advise it, but that's not that terrible. I said, you smoke? She goes, yeah. I said, okay, well, what do you smoke? She goes, marijuana. Oh, okay. Are you still doing that? Yeah. Okay. Did you do that for your IVF cycle? She's like, yeah, no one told me not to. And we wonder why the cycle failed. Hello. So literally, I said to her, I don't care if you have $50,000 worth of IVF coverage. Okay. I am not doing your cycle unless you are 8 weeks, marijuana, tobacco, alcohol free. Okay. Oh, she did not like me at all. Okay. Like, I'm even surprised she came back to see me. Anyway, I did get her pregnant. We took her through a cycle, made an embryo, froze it, put it back in a frozen cycle, and she did get pregnant now. She only had one embryo that was good. Didn't have any extras, and anyway, it's super important. So yes, marijuana can affect your gametes, and alcohol, I think in moderation, when you're trying to get pregnant, I think before ovulation, maybe 2 to 3 drinks a week, a glass of wine or something like that. Anything in excess is bad. Okay. There's definitely study after study after study that says excess of alcohol, there's a higher incidence of infertility. There's one Italian study out that actually goes against that. And patients in Italy who drank more got pregnant at a higher rate. So it's kind of weird. So there is some controversy, between studies with alcohol, but there is one Italian study that says drinking is good for fertility. So I say moderation. I say, if you want a glass of wine or, on the weekend, 1 or 2 drinks, I think that's okay. I think, doing something on a daily basis could definitely affect your outcomes. All right. So I know I talked really long. Hopefully I inflated for anybody, but went over my time limit a little. So this is just, my advice that they asked me for was just never give up on a dream just because of the time it takes to accomplish it. And again, when you look at doctors, I mean, and look at you guys are just starting your journey. I mean, when you look at doctors, I mean, I just look back on like my life personally, and I'm just like, oh my gosh, I graduated, you know, and I went all the way, I went straight through. I mean, you guys now you're taking gap years and working for a couple of years and getting, you know, experience as scribes or, you know, techs and, you know, phlebotomists and things like that before you can apply to med school. I mean, it's just so long. I mean, it's 4 years of college, then, you know, it's either a gap year, your time getting experience, then it's, you know, 4 years of med school. And then, I mean, I did 7 years post-grad. Okay. I did the internship, I did 4 years of residency and 2 years of fellowship. I mean, it still would have been 7 years now because the fellowships, all the fellowships now are all 3 years after OB because they want you to do a year of research. So the timing, if I had done my fellowship, you know, I think changed like 5 years after I graduated, it would have been, I would have done 8 years post-grad. So it's such a long journey, but I have to tell you that, you know, I've been doing the same thing now for 20 years. It was the best decision that I ever made, well, to subspecialize, but I think I'd still like it if I was delivering babies. But I mean, I just really, you know, you have to pursue your passion. When I went through my rotations, literally, it was hysterical. My father wanted me to be a dermatologist, okay? Wanted me to be a dermatologist. I did 3 dermatology rotations during medical school, trying to convince myself that I liked burning off skin cancers with a little freezy gun. Okay, couldn't do it. I came out, Dad, I can't be a dermatologist. I just can't do it. I can't see one more skin cancer. I just can't do it. Then he wanted me to be an ophthalmologist. I did 6 weeks of ophthalmology. Okay. I mean, you only really need to see one cataract operation, okay? Like they're not that interesting. I mean, I must have seen a couple 100 cataract operations. I'm like, I can't look at eyeballs every day. Dad, I came out, Dad, I'm sorry, I can't be an ophthalmologist. I mean, I really tried to like derm and ophthalmology. And I came home and I like, Dad, I like OB on my first OB rotation as a 3rd-year medical student, my first night on call, okay? Literally the resident who was on let me deliver a baby. Like I delivered a baby and I was sold. I'm like, this is the funnest job ever. So I came up, Dad, I want to be an OB-GYN. He's like, you're nuts. You're crazy. Like you never have a life. Anyway, so I'm glad I'm a subspecialist. Again, I really enjoy doing babies. I delivered babies for 7 years, but I think infertility is a very niche field. A lot of people don't even know about it. And it's super cool. I'm not sure whether you guys have more questions. I don't see any more. So if there's no more questions, this is my info, okay, here. Basically, I'm on Instagram at Dr. Ellen Wood. The pandemic has made me a fan of TikTok, even though never even heard of it before last February or March. I mean, really, never even heard of it, seriously. I'm on Facebook at Dr. Ellen Wood. That's my email address. If anybody has questions, feel free to contact me. That's my office number. And again, our office does have a website. It's www.ivfmd.com if you just want to check out our practice. Anybody who's having fertility problems really shouldn't be an undergrad, but if you are, we do virtual consultations all over the world. Like this pandemic has made us computer experts with doing virtual stuff and talking to patients and making treatment plans. I'm still a traditional doctor. I still like to see patients in the office. I have a hard time looking at your uterus and your ovaries over the computer. So even if I talk to you on the computer, I still want to see you in person. Anyway, so thank everybody for their attention, their questions, and hopefully, you know, you learned a little something because we're a super subspecialty, so it's not something that people normally get any exposure to.
Thank you so much, Dr. Wood. This was an absolutely amazing presentation. Everyone learned so much, and we absolutely loved having you today. We really appreciate it.
All right.
For everyone still watching, the Google form has been posted in the chat box, and it will be posted shortly in the description of this video. And you have 30 minutes from now to fill that out. And once again, thank you so much, Dr. Wood. We really appreciate it.
Well, you're welcome, Sophia. Yeah, I'm happy to do it. Again, there's just so much in my specialty. I'm just so passionate about it. I'm sorry I went over.
Oh, no problem. No problem at all. We absolutely loved learning from you. So no worries at all for going